All right. Thank you, everyone. I'm Laura Levin. I'm from Lurie Children's, and I'm going to be discussing our screening rates in patients during in our institution. Okay, so to give a little background, which most of you all already know, but the reason why the project kind of started was to kind of prevent patients presenting in DKA. And so when we look at these patients, we want to kind of give them the opportunity to not get so sick and catch it before, they come in DKA because that's the most common presenting sign. We also want to broaden the screen for type 1, and we can reduce the number of patients to identify those who are candidates for TZIELD. And we also kind of focused also our efforts on individuals with a family history of type 1, obviously, or a personal autoimmune disease family history compared to the general population. And our project aimed to increase the rate of patients screened for type 1 by 15% from baseline over an 18-month period. So here's our fishbone diagram. And in our fishbone diagram, we first wanted to identify 4 key categories that were contributing to our low screening rates because we were having issues initially with the project with screening. So we identified education, workflow, equipment, and equity. And then we went on to develop our key driver diagram. So from our key driver diagram, we identified those 4 causes, then developed secondary drivers. And from the secondary drivers, we were able to kind of decide what our interventions were going to be. And I'm going to go over that in a little bit. But as you can see, our interventions were derived to address both the secondary and primary drivers. So here's kind of our background of our institution. We have 8 clinical satellite sites, and typically at each of those sites, we have 1 to 2 providers at each site. So it's not like we have a comprehensive 5 providers at each site. We have a total of only 13 diabetes providers out of 28 providers total. And the time frame was from July 2024 to July 2025. So the interventions that we decided to focus on were, 1, we worked on education given to providers in our department regarding the rationale and process for screening during our monthly division meeting. So we were concerned because a lot of the providers who we work with don't all see diabetes patients. And so when we were kind of addressing this, we were like, we need to educate the other providers on why this is so important. The other intervention we did was we created prompts in our diabetes clinic flow sheet in the EMR to kind of address at the visit, talk to the families about screening. We also offered multiple screening options, including lab draw and enable kits. And we also discussed with families at the visit to say, should you bring in your other child, we compare the visit together with your type 1 patient so you don't have to kind of come in for a separate visit. We also hung informational posters displayed in clinic rooms to kind of raise patient awareness. So when families were sitting in their exam room, they saw this poster that kind of gave information about screening. So when we talk about barriers, I want to break it down into provider barriers as well as patient barriers. I think for us, the biggest barrier was provider buy-in. A lot of our providers, like I said, don't treat type 1 diabetes or type 2 diabetes. They do endocrine. And so in their eyes, they didn't really understand screening. They didn't know how to do it, and they were very overwhelmed by it. But once we kind of sat them down and provided a PowerPoint presentation to them and explained how to do it, I think they felt more comfortable with being open to the idea of talking to their patients about screening. The other concern that the providers expressed was, time. Will this take away from my visit? I don't want to talk about something else other than hypothyroidism. So that was another issue. But again, I think once we gave the education, a lot of our providers in our division were much more open to kind of talking about screening. From a patient barrier standpoint, before Tzield exists, I thought families were often very, weary, saying, this is going to cause me more anxiety. I don't want my other child to know. What do I do about it? But now with Tzield, I think we've kind of overcome that barrier and we're offering this to families. The other concern families expressed was additional costs, so financial burden, because taking them to extra appointments, the lab draw, all that was also a concern for these families when we talked a little bit about screening. And a lot of families were not even aware that Tzield was an option. Lastly, children under the age of 8, obviously right now are not, able to receive Tzield. So some of those families were like, I don't want to put my 2-year-old through the testing because if there's nothing to do about it. Here's our control chart. And as you can see, it starts from January 2024 to July 2025, and we see an upward shift in the mean screening rates after our initial intervention. So the baseline screening kind of starts from January 2024 to July 2024. And that initial intervention was first we did provider education, and right after we did the provider education, we did see an increase in screening. And then we tracked our other interventions, like I mentioned, the order set and Smartsheet. And furthermore, we did see kind of rates ebb and flow month to month, but we kind of nudged our colleagues and sent emails out to everyone saying, can you remember to screen? And once I kind of sent those emails out, like the next month, I'd see an uptick in screening again, but then I'd let it go for a couple months and we'd see a downward trend. So I think it was just kind of reminding my colleagues to, this is an option. Please offer your hypothyroid patients, this option. And we did see an upward shift. Okay, this slide was taken from the T1D exchange, and it's looking at the 4 participating centers. And as you can see, our screening rates are very high. However, to my surprise, our stage 2 identified patients were actually only 4 out of 282. So it was a low percentage. The other centers had a little bit of a higher rate of identifying the stage 2 patients. But when we look at the national percentage, I think ours is sort of in line with what they're seeing for those screens. So in terms of key takeaways from this project, I think, we have to kind of streamline our screening process. And we were able to do so through order sets, provider education, and also integrating it into the flow sheet, which those 3 interventions really did increase our screening rates substantially. I did find that the standardized order sets that we created, those are like a low effort but high impact intervention. And we are starting to share that also with other community providers, other specialty clinics. So now that there's a whole order set, they don't have to ask us what they have to order. And hopefully that will generate more screening as well. And like I said before, I think the variability in the monthly screening rates was secondary to provider familiarity and reminding them to kind of do this because it wasn't on the forefront of their minds for a lot of the providers. And then the impact of expanded screening rates on patients who receive T1D, I think, is difficult to assess right now just due to the low rates of autoantibody positivity and our screening rates at our institution. So we want to kind of continue screening, increase screening, and see the impact. So in terms of next steps, one of the things we're really working on is expanding to the community providers and other specialty clinics such as GI and rheumatology and partnering with them to kind of talk to their patients, their celiac rheumatoid patients about screening. Our goal is to establish a dedicated screening clinic, which we do not have as of now, with our nurse practitioner, but we're working towards that. And then we also created a letter to all of our type 1 families, kind of discussing screening and that their other children are eligible. And we're going to send that out actually in the next month. And hopefully all these efforts will continue to increase screening. Here's my acknowledgements, and thank you.
All right, awesome. Thank you, Dr. Levin. We have about 4 minutes to open up for questions now. Got 2 microphones, so I can try to run them around here.
Hi, I'm Grace Kim from Texas Children's. I'm not actively involved with our T1D screening, but a lot of our team is. I was just wondering, you said provider education. So I was just wondering, what are you educating? Like, if you have a patient with hypothyroid or any autoimmune screen at one time, like what specifically are you asking them to do? If it's not like a family member with diabetes. Thank you.
So when I say When I said provider education, we talk to everyone who sees the patients for hypothyroidism, talking to them about saying, because you have hypothyroidism, you're at increased risk for other autoimmune conditions. And so now we are screening a lot of our other children for type 1. And same with the GI and celiac patients as well.
No, this is people on Zoom have to hear you, so that's why. Sorry. Sorry.
I was just wondering what your experience has been in terms of where you're ordering the tests. Like we've been trying to figure out using like LabCorp diabetes autoimmune profile, and we just don't know what to tell patients in terms of coverage. I know it says it should be covered, or we've used Ask screening program in the past as well. I just didn't know what other centers were doing for that.
Oh, sorry. For us, we're doing our Lurie Children's Lab, but we also have Enable kits in our clinic. And right now, Enable kits are free. They're running them at no cost. And that is a great option, I think, for a lot of families. We also do send them to Quest, and Quest is significantly cheaper.
Individual, or is there a profile?
They're at Quest. I think it's 3 in one group, and then you have to add the ZNT8, I think. I have an order set through Quest though too.
Sorry, my name's Carrie. I'm from UC Davis. I have a follow-up question in regards to what you just said. What is Enable Kids?
Okay, so Enable kits are it's Enable Therapeutics, I think, or biosciences, and it has you poke the finger, you kind of dot on 3, I'm making it very simple. You dot on 3 little circles and you submit it back to them, and they actually give you your antibody results on 3 antibodies. So they don't have all 5, they have 3, but they state that their sensitivity is like 98%. And they just happen to give me a presentation, but they said that Quest, I don't know if this is accurate, is only about 50 or 60%, which surprised me.
Sorry, I have another follow-up question. There was a bug on me, so I guess that was somewhat of an emergency. Anyways, so it sounds, I guess I'm just trying to figure out logistically how you guys are doing things. So it sounds like you send people to the lab and you try to figure out some sort of payment situation, but then are you able to have like a clinic visit and not be able to bill, or are you able to bill successfully?
No, we bill for the clinic visit. We just pair it with so if a patient comes in with type 1 and they bring the sibling, we just make a separate visit type for that sibling and bill it.
Okay, and you guys are able to successfully do that?
Yeah.